Ay,
Si Mommy.
si Mama.
Ang ilaw ng tahanan, tagapangalaga ng pamilya.
Habang buhay na tagapagtanggol ng kanilang kinabukasan.
Habang buhay na tagaturo ng nutrisyon at kalinisan.
Habang buhay na gabay para sa bawat pagbakuna.
Upang habang buhay ang kanilang disiplina.
Lalaban habang buhay at naman ang sakuna.
Upang ang angkan ay maging malakas at masigla.
Dahil ako si Inay.
Si Mommy.
Si Mama.
At habang buhay ang aking pagsinta.
Para sa aking pamilya.
Mama, ang panata mo. Panata rin po namin sa Sanofi. Kaya habang buhay din ang aming pagsisikap. Napabutihin ang aming mga bakuna, health program at treatment para sa mga chronic diseases. Habang buhay na paghanap ng mga solusyon.
Habang buhay na pagsulong.
At naman ang sakuna.
Para sa pamilyang Pilipino.
Sanofi. Panata rin po namin sa Sanofi.
Ako si Inay.
It was once all about the race. If you weren't ahead, you were out of the game. But when everything stopped, we saw the chance to change the game
Sanofi.
and begin a new path. This time, the bottom line won't be our finish line. This time, we'll chase investments whose real interest is care. This time, every step we take doesn't just change the world, but protects it.
Sanofi.
And we'll chase this time, our tech advancements will propel human betterment. This time, we will run the longer race. Because the most rewarding pursuit is leaving the world greater than what it is.
Uy, ayos yan ah.
Yes, Dad. May gusto ka bang sabihin?
Sabi ng mami mo may girlfriend ka daw.
Okay, tapos na yung conversation. Thank you.
Gets ko anak. I was young once. You want to see her.
Please, Dad. Stop talking.
I just want you both to be safe.
And there it is. You made it awkward, Dad.
You have to be responsible, anak. I know you don't want to be told what to do.
Please, Dad.
That's why I want you to
Teka
get
lang,
vaccinated.
Wait, what?
Vaccination, anak. Bakit? What did you think I was talking about?
No, nothing. Never mind. Of course I want to be vaccinated.
Kaya kita, anak eh. Mana ka sa daddy mo. Tara!
No matter how much we prepare our kids, diseases can potentially disrupt their future. Help protect their dreams. Ask your doctor to know more about disease prevention today.
Good afternoon, ladies and gentlemen, mayors, and welcome to our first Liveable Cities Lab for this year. Our topic today will be universal healthcare, better health for all, presented in partnership with Sanofi Pasteur, together with the League of Cities of the Philippines and Globe Telecom. The webinar will discuss post-pandemic recovery, focusing on three key pillars: preparing public health systems for future pandemics, prioritizing universal health coverage, and promoting healthier societies via holistic policies. The Livable Cities Challenge is also working with Sanofi Pasteur to expand our Livable Cities Health Dashboard to promote universal healthcare for better health management. Today's lab brings together experts who will speak about how the country could provide every Filipino with quality healthcare that is accessible, efficient, equitably distributed, adequately funded, and fairly financed. Our speakers and panelists today include national scientist of the Philippines and Ramon Magsaysay awardee, Dr. Ernesto Ochoa Domingo, Baguio City Mayor Benjamin Magalong, Chief Health Program Officer for Disease Prevention and Control from the Department of Health, Christian Edward Lim Nuevo, and Sanofi Pasteur General Manager Kashmira Prabhu. Now, before we begin, let's review a few safety reminders. First, be aware of your surroundings while the webinar is ongoing in case you need to stop due to an emergency. And second, please always stay safe and practice social distancing if you are out of your home. Furthermore, this webinar will be recorded and will be available on the Liveable Cities Facebook page. Questions may be asked in the Zoom Q&A chat box, which includes a feature that allows the audience to vote on questions posted by others by simply clicking on the thumbs up icon next to the question. Some of these will be answered directly by our speaker or their staff in the chat box, while other questions may be parked for later in the open forum. If you are joining the webinar on Facebook Live, you may place your question in the comments section of Facebook, and our staff will pick it up and forward it to us here in the Zoom room. At the end of this webinar, we will invite you to please fill up our feedback survey form. Your response will help us improve our Liveable Cities Lab series. You may also get a certificate of participation by answering the corresponding questions in the survey. Now, before we start to get the program going, we usually ask a couple of questions, poll questions from our audience. And so we'll start off with a simple one. The first question is, where are you joining us from? Okay, where are you joining us from? Your choices are Metro Manila, rest of Luzon outside of Metro Manila, Visayas, or Mindanao. So let me repeat, where are you joining us from? Just pick one, Metro Manila, rest of Luzon, Visayas, or Mindanao. Okay, and the response, our audience today is very, very Luzon-centric, more Luzon-centric than our usual audience. 42% from Metro Manila, 48% rest of Luzon, and just 4% from Visayas, 5% from Mindanao. Okay, so that's our audience mix for today. Now, let me ask a second question, which is, I think, of vital interest to all of us in this COVID situation. The question is, are you vaccinated against the COVID-19 virus? Okay, so here are your choices. You're partially vaccinated, meaning you got one shot. You're fully vaccinated, which means you've gotten your primary series. You're fully vaccinated and have gotten a booster, or you're not vaccinated at all. So those are the four choices. Partially vaccinated fully vaccinated with the booster, or not vaccinated. An important question for all of us. Okay, so this is encouraging. Everybody here is actually fully vaccinated. So no one's left with one dose and waiting for a second dose. And more people have received the full dose, the primary series, plus the booster, and none are unvaccinated, which is a great result from this audience. So thank you. And if you ever get a chance, please tell your friends, tell your family, important to get your booster. And just a reminder, boosters are now available for people who have had their second dose 3 or more months ago. It's no longer 6 months, but it's 3 or more months ago with your second dose, and now you're eligible for your booster. So thanks very much for that. Now, just let's get on with the program, and let's start with our first presenter. A good friend of ours, good friend of mine. We've worked together in T3 and in the COVID response for the last couple of years. Mayor Benji Magalong, he's a retired police director general. He has spent over 38 years of service in the Philippine National Police. And after his retirement from the police force, Mayor Benji entered into the private sector and took post in Steel Asia as Senior VP for Operations. He was a member of the board of directors of PNOC and an independent director for Infradev Holdings. Eventually, he started his political career with a goal to rehabilitate and revive the city of Baguio. Among the mayor's platforms are speeding up government services, responsible tourism, revitalizing the environment, effective traffic management, and expanding health and social services. Ladies and gentlemen, let's please welcome a good friend of mine to speak about what he's doing about health services in Baguio City and his experience, actually. He's a very hands-on manager with COVID response as well, which has given him a great background into the needs for the public health situation in Baguio. Let's please welcome Mayor Benjamin Magalong. Mayor Benji, the floor is yours.
Thank you very much, Sir Bill. Let me forego with the usual traditional greetings and just greet everyone a pleasant afternoon. So let me just share my slides. Thank you. Thank you, Sam. On behalf of the City of Baguio, I would like to thank the organizers from the Liveable Cities Challenge Philippines for inviting us to share our experiences and strategies we put in place to help manage this pandemic. To start with, allow me to present a short profile of our city. Baguio City is popularly known as a summer capital of the Philippines due to its cold climate. Compared to the lowland area, our temperature is cooler by 9 degrees Celsius. With a land area of 57 square kilometers, Baguio is originally designed for 25,000 to 30,000 people. However, with rapid urbanization, our population has already reached 378,000 in 2020, with an annual population growth of 1.54%. Baguio is located in a mountainous area within the Cordillera Range, and elevation varies from 900 to 1,600 miles above sea level. The topography of Baguio is mainly hilly, rolling terrains, and mountainous. This pandemic affected all sectors. We have seen people lose their jobs, livelihood, income, and even loved ones. In Baguio, as of January 17, we currently have 3,691 active cases. Our total COVID cases is 34,600. In the following weeks, we are expecting a surge in cases due to the Omicron variant. In terms of our vaccination status, per our local standards, 288,000 individuals have already received their first dose. This makes up 102% or 102.6% to be exact of the eligible population of 281,000. 268,000 adults or 95.43% have already received their second dose. And 63,072 individuals have already received their booster doses. For the pediatric population from ages 12 to 17, 77.9% have already received their first dose and 70.4% have already received their second dose. Moving forward, I will be sharing with you our major initiatives in addressing our current situation, including lessons learned during this pandemic. Contact tracing has always been a strength of our local government unit since March 2020. It has three major features: data collection, geospatial processing, and link analysis. These tools guide us in coming up with a comprehensive analysis of COVID-19 cases so that we can come up with appropriate interventions. And to monitor our vaccination data or data, we developed the Baguio Inoculation Digital Application System, which is a safe, seamless, contactless, and sustainable vaccination registration and master listing. With the uncertainty of this COVID situation, Baguio sustained unregulated entry of travelers to the city by allowing only vaccinated individuals to enter the city. Essential travels and returning residents are required to register at hdfbaguio.gov.ph, while leisure travelers must register in our visita.baguio.gov.ph. Since we encourage home isolation for asymptomatic and mild cases, the city developed its own COVID-19 home care, a telemed platform that is designed to reach out to those home isolated patients to check on their conditions and if they are in need of some medical attention. Should there be a need for medicine, this will be referred to the concerned district health center. Aimed for seamless and streamlined business transactions, we developed online platforms such as the Business Permit Application Service System for online tax assessment and payment, and BillPass to process building permits. The city has been doing its best to ramp up its vaccination program through various strategies that will provide convenience to the general public and to speed up the processing of vaccines. An online platform, vacunabagyo.gov.ph, was developed for pre-registration. During a time and motion study conducted in a vaccination center, it took an average of only 2 minutes and 36 seconds to screen each vaccinee before the actual job. In addition, aside from setting up big spaces for our vaccination centers, people have the option to get inoculated in their own health district or avail of our drive-through vaccination scheme. We also deployed mobile vaccination teams that go around barangays. This meant to reach individuals who cannot go to any of the mega sites due to limitations brought about by their age or health conditions. And simultaneous with COVID inoculation, our City Health Office implemented our own local immunization program to prevent other types of illnesses and diseases. Early on during this pandemic, we converted the defunct Santo Niño Hospital into an isolation facility, which can cater to almost 400 patients. It also served as a step-down facility. This foresight turned out to be the right decision and the right direction, especially when we got hit with the Delta variant and now with Omicron. Granular lockdown is a strategy to isolate certain puruks, streets, houses, or compounds where there are clusters of cases. It prevented the movement of potentially infected persons that may cause further spread of the disease. Food packs from our city's Social Welfare and Development Office were coursed through the concerned barangays for faster distribution to the residents of lockdown areas. We established the Baguio One Hospital Command Center to address the gaps in terms of coordination with Cordillera One Hospital Command and with the other hospitals and clinics. Through this, we procured 250 oxygen tanks to lend to patients who need oxygen supply in their homes, for a total of about 450 tanks at present. This was part of our Delta variant contingency plan that helped a lot of patients who were not admitted in our hospitals. The public is continuously reminded to practice good hygiene by continuously washing or sanitizing their hands. Last year, prior to the rainy season, our city Disaster and Risk Management Office initiated the joint inspection of evacuation centers and schools that are regularly being used as temporary evacuation centers. One of the requirements including the presence of functional wash facility with adequate supply of water. We would perhaps recommend to the Department of Education to do the similar inspection in schools prior to the resumption of face-to-face classes. Last year, we endorsed to the DSWD project to install wash units in 60 barangays. It is currently being executed. We also received a technical assistance grant from the Asian Development Bank for the Sanitation Behavior Change Strategy Project. ADB will be installing wash units in other barangays not covered by the DSWD. The increasing demand for disinfection services in offices and establishments, the city brought its own machine in 2020 to produce its own supply of disinfection materials and liquids. We provided these for free to hospitals, government offices, public utility vehicles, and barangays. To strengthen our local health system, one critical aspect is the rehabilitation of our district health center and constructions of new ones. This will bring basic health services to the people to ensure that everybody will be served. This will also prevent the congestion of patients in our main health center and hospitals. We were able to source out funding from the national government, from DOH, from the DPWH, and from some senators. From the completion of the annex of the City Health Service Office, construction of 2 super health centers, expansion, repair, upgrading of 3 district health centers, and the construction of 2 isolation facilities. Physical distancing is part of the minimum public health measures. Since people tend to crowd in central business district, city public market, and business establishments, part of our recovery plan is to build additional satellite markets and other amenities to bring the services closer to the people without the need for them to go to the central business district and to the main market. One of the lessons we learned in our pandemic response is the importance of having an action plan for any type of disaster. With the absence of a contingency plan for emerging diseases, our City Planning and Development Office initiated the preparation for our strategic action plan for COVID-19, transitions plans from quarantine status, and COVID-19 early recovery plan. Mid-July last year, we started preparing our contingency plan against Delta variant 2.5 months before the arrival of that variant, and monitored weekly the critical action areas such as the need for sustainable supply of oxygen, critical medicines, PPEs, isolation facilities, and stricter border control. And as a result, we were able to manage the variant, the Delta variant, and in just 1 month and 17 days, we were able to bring down our cases. As early as November last year, we started planning again for the Omicron variant, which we are currently implementing and experiencing. The City Health Services offices, together with the City Disaster Management Office, has dated the DRRM for Health Plan. Realizing the importance of a preparedness plan, the CDRRMO initiated through workshops the preparation of the local action plan for emerging and re-emerging diseases, taking into consideration the lessons drawn from this current pandemic. This is our model of evidence-based response and policy making in Baguio City. I hope that by sharing our experiences and expertise, we may provide as a guide as well as the inspiration toward the pursuit of a safer life and robust economy for our country. Thank you, and I wish everyone a productive and fruitful engagement. Mabuhay po kayong lahat.
Thank you very much, Mayor, for the comprehensive report. You know, prior to COVID, we rarely heard of mayors speak about their public health care plans for any city in the Philippines. And now Mayor Benji is just one of many mayors now who get into such detail, not only on the buildup of their infrastructure and services, but ultimately how they're even planning their city to, I guess, kind of decongest the central business areas, right, Mayor, so that you can bring the businesses closer to the people rather than have the people, you know, flock together and crowd into certain business districts. So, Mayor, that's, you know, really fantastic, and thank you for sharing that with us.
Thank you, Sir Bill. Thank you.
Yep, thank you, Mayor. Let me go to our next speaker, Dr. Ernesto Ochoa Domingo. Dr. Domingo is a national scientist of the Philippines, professor emeritus at the University of the Philippines College of Medicine at UP Manila. He is a specialist in hepatology and gastroenterology. He organized the UP Manila Liver Study Group and undertook important investigations of viral hepatitis and liver disease, establishing a causal link between chronic hepatitis B and liver cancer. His study has saved millions of individuals from life-threatening illness and decreased healthcare expenditures by identifying the preventive approach to liver cancer. He has fought for hepatitis vaccines to be made mandatory and available to all, as he is worried about the poor's access to healthcare. He has also successfully advocated for a bill that provides annual fiscal assistance for neonatal hepatitis immunization by working closely with politicians. He has received the 2013 Ramon Magsaysay Award for his work in public health care. And today we are honored and privileged to have Dr. Ernesto Ochoa Domingo address us and speak on the topic of universal health care for better health management. It is my pleasure to welcome Dr. Ernesto Ochoa Domingo.
Thank you, Bill. And I'd like to start by greeting the participants in this webinar. I am supposed to talk on universal health care, and in so doing, I would like to touch on three major topics. First one is a definition of universal health care. The second is to answer the question, why is it very important, and why is it that more than half of the countries of the world adopted universal healthcare as their healthcare system. And finally, I will raise some issues on universal healthcare because this is our official healthcare system. The law has been passed sometime in 2019. As I start, let me tell you a very, very short personal story because this is relevant to the slide that I'm showing you. When I was in fellowship training abroad, the training requires that I do research, and I did research under the tutelage of a very distinguished researcher on tropical disease at Case Western Reserve University in Cleveland, Ohio. His name is Kenneth Warren now. Subsequently, Kenneth Warren became the director of the medical divisions of the Rockefeller Foundation, a very big supporter of medical research. And while he was the medical director, he spent more than $100 million of the foundation's money. And mind you, that was in the late 70s, to support what he called the great neglected diseases of mankind. And what are these great neglected diseases of mankind? Among them will be malaria, tuberculosis, schistosomiasis, intestinal parasitism, which is mostly tropical diseases. Now, why did I mention that story? I mentioned that story because when you ask a doctor what is the most important problem in health globally, I bet you the answer will be a disease. Little did we know that in health, maybe the disease is not the problem. There may be something more. That's why, as a teacher, I have always told my students, don't ever think of medicine as purely a biomedical science, because medicine is a social science. So in 2010, the Lancet organized a commission, international commission. The membership are very distinguished. They are mostly public health people. Many of them have been secretaries of health, to really look at the most important health care problem globally. And this is the statement that they published, and I will read it to you. That's the first slide. They said that the most important health care problem globally is the glaring gaps and inequities in health, both within and between countries, underscoring the collective failure to share the dramatic health advances equitably. The best proof of this statement is going on now, the pandemic. And what's that? Look at the way vaccine has been distributed. The first world countries are already giving multiple booster doses, and yet there are many, many countries who have hardly vaccinated more than 10% of their population. That is a very good example of inequity. So in 2008, Dr. Quasi Romualdez, the late Secretary of Health, and I were tasked by the University of the Philippines on the occasion of its centenary year to deliver a back-to-back lecture. Dr. Romualdez is supposed to look at the state of health of the country, and I'm supposed to respond by saying or by telling how the University of the Philippines responded to this health problem. In preparation for this lecture, we worked for 9 months studying the health situation in the Philippines. And one of the products that we sought to capsulize what we thought is the most important health problem is shown in the next slide. Next slide, please. Next slide, please. Hello. Next slide, please. Okay, thank you, thank you. Now, this slide has 3 columns. It says symptoms of dysfunctional healthcare system, selective measures, health measures across economic status. It has 3 columns. The leftmost column are the health measure, and then you have 2 other columns comparing the incidence of this health measure between the rural poor and the urban rich. So what was measured? LEB is life expectancy from birth. IMR is infant mortality rate. MMR is maternal mortality rate. FR is fecundity rate, or how many children they have. EPI is how many children are able to complete the expanded program of immunization. And the last one is medical expenditure per capita. Later on, I'll measure another one that is very, very important, not included here. Just look at this, and I will pick only two because time does not permit me to elaborate on all of this. The tremendous advance in medical science enable the human being to increase their lifespan by 2 times, doubling of lifespan within a 100-year period. And yet, at this very time, very few poor will go beyond 60, while their counterpart rates will be going 80. The second is medical expenditure per capita. The rural poor, the rich spend at least 20 times more than the poor because they don't have money to spend. They're consuming much more. And to top this, when you look at our national health expenditure, 54% of it is still out of pocket, which means that since the poor do not have pockets anyway, the majority of consumption of health goods by way of expenditure is still the very rich. One last item I did not include, but I'm telling you now, is the rate of cesarean section. You know, from the medical point of view, the usual rate of cesarean section is 15%, 15%, 15 cases per 100 pregnancies. In the poor, only 1% get. So 14% needing the cesarean section did not get it. But the rich are not doing very well either because they get 30% cesarean rate, which means many of them are getting cesarean section when they don't need it. And you know the reason for that. We were so disturbed by this data that which we actually know, but really ignored. And that led us to organize the so-called Universal Healthcare Study Group at the UP Manila in 2008, long before the Lancet Commission published its finding in order to advocate for universal health care. The question is, what is the reason for these inequities? Can we have the next slide, please? Next slide. Next slide, please. All right. This is again from the Lancet Commission. Why is there inequity? One reason is summarized by this slide, and let me read it. Global trend in health system. Left to their own devices, health systems do not gravitate naturally towards the goal of health for all through primary health care as articulated in the Declaration of Alma-Ata. I will go back to the primary health care aspect of this later on, because there are 3 worrisome trends. If you let the health system by itself, this is what will happen. There is a disproportionate focus on specialists, tertiary care, often referred to as hospital centrism, fragmentation as a result of vertical health programs, and the pervasive commercialization. Let me just mention one item for each. When I was chairman of the Department of Medicine of UPPGH, out of 150 faculty members I have, no one is a generalist, all are specialists, and that proves the number 1. Number 2, fragmentation. Even now, with the Department of Health, you will see vertical program. For example, there is a program on malaria, there's a program on TB, and so on and so forth. These are called vertical program. What is meant by that? It is as if the disease exists in isolation, but the disease occurs in communities and affect other health systems. And the third is pervasive commercialization, where the money is. When you look at health services and health goods as something that you must procure and pay for when you need it, then that is the formula for inequity, because not everyone can pay for the health care that they need, or the medicine or other health needs that they will have. So this is the development of health system that is allowed to go by itself. Now, can I have the next slide, please? Slide 4, please. The answer is, what is the answer to this health system characterized by inequity? This is the answer provided by the Lancet. Global purpose of healthcare system is to assure universal coverage of high quality, comprehensive services that are essential to advancing opportunities for health equity within and between countries. Please remember that the central requirement of a healthcare system, as shown in this slide, is what? Equity, to address inequity. Universal healthcare system, sometimes called universal healthcare coverage, is now the dominant system adopted by most countries of the world. And the way it is done by countries differs a lot. For example, Germany has a very long history. Even the time of Bismarck, there are already universal healthcare. The national healthcare system of England, which is probably among the best, started right after the war when the country was broke and they have hardly anything to start with. And yet they adopted universal healthcare. So the most dramatic thing that I learned about adopting universal healthcare is one day I was listening, about 2 or 3 years ago, I was listening, actually looking at the TV news, and there was a news item that said the president of Indonesia announced today on TV that all Indonesians are covered by universal healthcare. Just like that, just a proclamation by the president. So what are the essence of a universal healthcare system? Can we have the next slide, please? Now, this definition or features of universal healthcare was crafted. This text was crafted by us, the Universal Healthcare Study Group, and you can see that just from the definition that it was crafted by academician, people in the university. If you give this to an ordinary person, he will ask you, what are you talking about? But anyway, I'm projecting this just to elaborate on it. And it says that universal healthcare is the provision. Incidentally, this was adopted and is the official definition of UHC by the Department of Health. So it says the provision to every Filipino of the highest possible quality of healthcare that is accessible, efficient, equitably distributed, adequately funded, fairly financed, appropriately used by an informed and empowered public. What is the meaning of all of this? Accessible, it means that the health facility that you need is very close to you, walking distance. Number 2, efficient. There's going to be no long lines where you have to wait for hours. For example, in the PGH, in the outpatient, people from the province are there by 5 o'clock. They will be seen by 12 o'clock noon. That's no good. That's not part of universal healthcare. Equitably distributed. No one group has more than others. Adequately funded. No default on needed services by reason of no funds. Fairly financed. No selective financing of services. In other words, one cannot say, I'll put all my money in this rather than this. Everything, every services is adequately funded. And appropriately used by an informed, empowered public. Consumers know what they need and where to access them. Well, as I said, this is a definition that is good for academicians, those are in the university. But if you put this to the average Mang Juan and Aling Juana, he will have a hard time understanding this. So we have another version of universal healthcare, which we actually used when we were already going out and propagating the idea of universal healthcare. And that is in the next slide, please. This is our definition addressed to the average individual. And we always start by saying, why did you come to such a definition? of universal healthcare? What is your moral and legal basis for it? Well, there is a moral and legal basis for it, and that is enshrined notably in the Philippine Constitution, Section 15, I think, and of course the WHO Constitution. And what does this say? It says that access to access to health services and health is a basic human right, just like the right to life, the right to happiness, the right to liberty, the right to travel, and so forth. Basic to human. You possess it, we possess it simply by being human. And then it is a legal basis as appear in our Constitution, in which case the state guarantees this. And it's guaranteed, but for a long, long time, it has not been given to us. So the definition for somebody who's not very conversant with the idea is, we say, when you're covered by UHC, simply because you're a Filipino, when you get sick, you can go to any health facility designated for the purpose, get treated, you don't pay anything. If you need higher levels of care, like you have to go to a secondary, tertiary hospital, you don't have to worry because they will be responsible for it. In other words, there is what we call it gatekeeper, but we don't like the word gatekeeper as if you are preventing people from coming in. It's rather the navigator. And that is the essence of a universal healthcare. A universal healthcare is based on primary healthcare. Strictly speaking, primary care, because we remove the primary healthcare, because primary healthcare implies that you also attend to the social determinants of health, among which is poverty. We are not ready to handle poverty. So we say primary care, that is when you get sick, you should be able to go to a place very near you, get attended to. If all you need is a paracetamol pill, then that's the end of it. But if you need to be examined, have x-ray, or even have surgery later on, that person who attends to you, so-called navigator, will be the one responsible to bring you to the place where you can get these needed services. There is no substantial pocket payment. You don't have to dig into your pocket. Anyway, you don't have any pocket most of the time. But it is not charity. You are not a charity patient because all of this is being paid for either by taxes or primary health premium, health premium. And therefore, I will go to my last slide. And my last slide, next slide, please, is what does it take to implement a universal health care? Certainly, there has to be reforms. And I enumerated only here about 6 what we call pillars of healthcare. And these are very, very important for a healthcare system to function. Incidentally, when the UHC was signed by President Duterte, sometime I think July 2019, the law specifies that within 2 years we should already have the system. But we still don't have it. And I can understand that because of the pandemic. But mind you, because I was involved, the IRR, the implementing rules and regulations, are already there, waiting to be implemented. Now, so let me just give some highlights on what this is. Let's start with health services. The basic, the very foundation of universal healthcare anywhere in the world, meaning to say you cannot get a good UHC without attending to this basic principle. The basis for universal healthcare is primary care. Primary care, in simple terms, I've already mentioned. Whenever I feel something pertinent to health, I can always access a facility nearby, and there is a health professional there who's going to attend to me. That is the essence, and that is the requirement. Regulation, health technology assessment, health policy, types of care, use of health products must be vetted. And in the UHC law, there is a body called the Health Technology Assessment Committee, which will be eventually housed in the Department of Science and Technology. That is very important because in a universal healthcare system, you cannot just adopt certain practices without being subjected to their efficacy, safety, and so on and so forth. Unlike now, you can introduce anything even on a national scale without a very serious study on whether that is helpful or not. The third is governance. As the law says, governance now is integrated at the level of the governor. I will not go into the reason. There was a long debate, there was a long study, but we all came to the conclusion that the level of integration of health services, health governance, health financing will be at the level of the governor. Human resource, this is probably the most important aspect of health sector reform for UHC. Because after saying everything, if you don't have the human resource, if you don't have the health professional there manning the ramparts, nothing will happen. So human resource is the most important of this. And this is a challenge to us because obviously the first question to be answered, do you want doctors to man the ramparts of primary care? The answer there is no. But you have to develop other health professional short of having a doctor, because it's unrealistic to expect that you will have a doctor for everybody. And human resource also implies that there has to be a major change, a major reform in how we educate our health human resource. And therefore, CHED is very much involved in this. The second most important aspect, I mentioned already that human resource is the most important. The second most important for you to get going, for us to get going, is information, real-time information. There have already been 2 major studies on this, on showing on how important actual, timely, and up-to-date information is in terms of intervention. I think that was alluded to by the mayor when he spoke. And there were 2 studies, the one done in Bataan and in the Bicol provinces, and another one in Tarlac, that shows the central role of information. And finally, finance. You can never finance UHC by PhilHealth. Impossible, no matter what you do. It cannot be financed simply by health premium. Remember, PhilHealth, where you pay a premium, is not for universal health care. That is for health protection, because the origin of PhilHealth is MaxiCare. That is financial protection. Very little to do with financing health, universal health care. The only thing that the primary thing needed in financing UHC is it must be based on tax money. And that's what the law says. For example, the law says that the tax will come from the sin tax, from the gaming tax, from all sorts of taxes that is incorporated into a global fund and entrusted, in this case, to the provincial people for them to budget according to their plan of action for the coming year. So that, in summary, is what universal health care. I hope my very fast presentation did not create more confusion than understanding. Thank you.
Thank you very much, Dr. Domingo. No confusion. No confusion at all. I think you have given us a very, very big picture that we are talking really beyond medical care, but it is really a far larger social benefit, a moral obligation. And I think very interesting your distinction about how it gets financed, how it gets funded, because automatically most people think that PhilHealth will cover And we already can see the problems that PhilHealth is having in reimbursing our hospitals for the protection that we all should be getting. But as you said, it should be financed by taxes, whether the sin taxes and the gaming taxes and so on and so forth. And most interestingly, I think most people don't realize that if I understood you correctly, it will be managed really by LGUs at the provincial levels.
Absolutely.
Okay, so this is going to be a very interesting discussion on how we're going to make this all happen. So thank you very much, Dr. Domingo, for the really excellent presentation and giving us these insights. Now, before I move to the next speaker, I just want to remind all the all of the participants in the audience that if you wish to ask your questions, we do have the Q&A box. You can vote on the questions so that actually, if you like a question, the most popular questions will rise to the top of the list. And we will save some questions, of course, for the panel discussion and the Q&A. So they'll be answered both in the box and in the live Q&A. So thanks for that. So let's move on to our next speaker, who will be Christian Edward Lim Nuevo. So Christian is currently Chief Health Program Officer at the Department of Health, Disease Prevention and Control Bureau, or DPCB. His work centers on the implementation of the Universal Health Care Act, particularly as it relates to strengthening of primary care and its delivery, reforms and transitions in health financing, and integration of governance and support mechanisms such as information systems and procurement and supply chain. He also leads the performance delivery unit of the Bureau, in charge of ensuring optimal Bureau operations and performance and efficient budget utilization. So I would say, following the description and the challenges laid out by Dr. Domingo, Christian's got a very big job ahead of him in the implementation stage of universal healthcare together with his team. So let's please welcome Mr. Christian Nuevo, and he's going to speak about strengthening the public health system for future pandemics. Christian, the floor is yours.
Thank you very much, Bill. So I'll just be sharing my screen, but yes, definitely agree. How do you follow the Dr. Ernesto Domingo and of course Mayor Benji Magalong? But what I will try to do with this presentation, a lot of it has already been premised actually very, very effectively by Dr. Domingo. Some of the key tenets on UHC and primary healthcare. But again, what I'll try to do is to shed a little bit of light on what the DOH is currently doing to assemble some of the resources and really roll out the reforms in the UHC Act. All right, so I guess I also want to start with this, and it follows through very well with how Dr. Domingo premised universal health coverage. So usually when UHC is discussed, people zoom in very quickly to very, very specific components like financing or service delivery or regulation or how will drugs be covered. While these very specific components do play a significant part in achieving universal health coverage, what's also important to emphasize is how we set the stage to what UHC means. And UHC in this case for the country really is founded on primary health care. Now, primary health care, as how Dr. Domingo also differentiated it, is that primary health care really is an approach to providing health services, making sure that the social determinants of health are addressed, making sure that health services are provided equitably, adequately, and comprehensively. So it's really all about the environment or the cities or the communities to which households, families, and individuals are situated in, which means making sure that we all are within healthy living, schooling, and working environment. So that's really the main goal of UHC. Right? So why is it important to premise UHC within this agenda? If we look at what actually determines the health of an individual, only around 20% can actually be found in moments in a healthcare environment. So when we seek care in a clinic or in a hospital, that's only 20% of what really defines healthcare for us. 50% can actually be tracked to our zip code, our education level, our job status, support that we get from our families or from social safety nets, our income level, and the general safety in our community. And of course, our physical environment also works as a way to facilitate how we actually reach better health as individuals and as households. All of these generally and strongly affect our choices, our health behaviors on whether we are going to smoke, we are going to drink, or whether we are going to participate in diet and exercise or in healthy sexual activity. So all in all, around 20% is actually within the leadership of the health sector, taking care of Filipinos when they are needed. But the rest, the remaining 80%, is actually a multi-sectoral agenda of protecting and enabling Filipinos to care for themselves and their community. So actually, if we look at what what Mayor Benji Maralong shared earlier about decongesting their business districts, in order to make sure that COVID-19 doesn't spread when people congest in only one area, that's actually protecting and enabling Filipinos to care for themselves and for their community. And his expansions on isolation units and critical care units is the 20% of that aspect, taking care of Filipinos when healthcare is already needed. And I guess I also just wanted to go back to what Dr. Ernie Domingo shared earlier, that the core tenet of primary health care is really primary care, preventive services. And the DOH right now, together with all other health agencies, are moving towards ensuring people-centered primary care. And this is defined as ensuring that every Filipino family is matched to a primary care provider or a primary care team that will ensure they receive appropriate services in facilities within healthcare provider networks connecting primary and inpatient facilities without experiencing financial hardship or financial ruin when they actually seek health services. So ensuring financial risk protection. So the agenda of universal healthcare is really founded on strong primary care. Now, why do we want to invest in primary care? And this probably is just a huge echoing to what Dr. Domingo already said. It addresses more than 80% of people's common health needs. And the agenda really is to prevent and to manage people's illness before they become expensive and complicated to treat. So we don't want people getting into very, very sickly situations, but actually address their needs right at the onset so that they don't progress to something more serious. It is more fair and equitable because primary care facilities are found within communities. Our clinics are within our reach, and our primary care provider is also within our reach. Globally, primary care is really the agenda or the cornerstone to to universal healthcare systems, and it also helps protect global health security by protecting and ensuring healthy communities and overall saving and improving lives. So in general, this whole UHC agenda of the Philippines really is grounded on primary health care and aspires for benefits both for patients and for providers. So usually when we talk about UHC, the spotlight is on patients, and as it should be, it really should be spotlighted to the patients. But at the same time, we also have to take care of our partners that actually provide these health services, our providers. So for patients, we want to reduce risk. We want to increase health literacy so they can make better choices, to increase access and affordability of health services, and overall improve quality and responsiveness. For our providers, we also want to set up an enabling environment where they can adequately and effectively provide services that they can. Increase also the literacy in the system of our providers so they can effectively navigate our households to higher levels of care as necessary. Compensate them with decent, predictable pay, and continue to allow them learning opportunities to improve their craft. So overall, combining these benefits for patients and providers will lead to happier and healthier communities, worry-free families, and of course, satisfied and fulfilled Filipinos. So after setting the stage on what UHC really means for the country, at least for the vision of the DOH and the government, what then are the specific enablers to really achieving a primary health care grounded UHC for the country? So I will just be identifying 7 activities or 7 key components, most of which are actually aligned with the 6 building blocks that Dr. Domingo shared earlier. So first one is on the realm of health promotion, improving health literacy and choice architecture for healthy behavior. So what we're showing here are 7 priority areas, 7 high impact areas that the Health Promotion Bureau is focusing on. Now, the idea here is to set up interventions both at the individual level and at the environmental level such that they reinforce each other towards pushing people towards healthy choices, right? So at the individual level, if we look back, there have been some milestones that we have experienced, such as the passage of the sin taxes, sugar-sweetened beverages, and even the graphic health warning for cigarette packs, right? So those are individual level nudges that push people away from unhealthy choices and towards healthier options. But of course, people should be situated within places and structures that facilitate this behavior or even reward this behavior. So more than 50% or at least 50% of our waking hours are spent in schools for students and in workplaces for employees. So these spaces should also be fostering the healthy behavior and healthy choices that we want at the individual level. So for example, in COVID, our very strong push for the minimum public health standard is actually setting up structural parameters that facilitate people to continue wearing their masks and sanitizing their hands as often as possible. So part and parcel of improving healthy choices and health literacy is also organizing communities and improving settings that facilitate such choices. If you get the chance to look at the Healthy Filipinas website, you will see health promotion playbooks for communities, and they have very specific and thematic areas that like what you see here: healthy diet, active transport, peer support group for the youth. And within each playbook, you can see an all-in-one packet of guidelines, some MOA templates or programs and activities that LGUs can actually adopt to help shape their communities towards healthy behavior. So if you have the time, we'd appreciate it if you can check out the Healthy Filipinas website. The second component is on governance and specifically defragmenting the local health system. Now, I want to kick off to what Dr. Domingo said earlier about re-centralizing our health system from a very, very fragmented one to something that is more centralized at the provincial level. So when the LGU code was first enacted in 1991, it really severed the relationship between your primary care provider and your hospital or inpatient provider, because the management was also different. Our primary care facilities are managed by municipalities and cities, and our hospitals are typically managed by our provinces or our governors. So it effectively severed the link for comprehensive and continuing care. So by elevating the integration at the level of the province, we actually get that opportunity to reconnect our hospitals and our primary care facilities together. So it's a governance approach. It's a governance intervention by re-centralizing to province-wide and city-wide health systems. And within these local health systems, of course, we establish what we call healthcare provider networks that actually provide care at the front line in a comprehensive manner. So this is, I think, the figure on HCPNs have been going around in a lot of webinars and conversations. But basically, the point here is that every individual, every household is linked to a primary care provider close to their home so that immediate care can be provided, whether they are healthy, just needing a checkup, or sickly in a non-emergency situation. And then the primary care facility, the primary care provider can then help our households, our families, navigate themselves towards what is actually needed. Do they need specialist outpatient care? Do they need to be referred to our hospital? Or they can be managed at the preventive level and reintegrated back to their communities right away. So you see how important it is to reintegrate at the province level in order to facilitate the connections from our hospitals to our primary care facilities. And of course, our networks will not work without adequate facilities. And historically, the Philippine Health Facility Development Plan has had very, very strong focus on hospitals or increasing inpatient beds. So yes, we've learned with the COVID response that we still need to increase our bed capacity. But at the same time, what we also learned is the need to expand the reach and the availability of primary care facilities. So a lot of the resources and a lot of the also approaches and plans are going to move towards expanding the capacity of existing primary care facilities and adding more so that we close this gap on our shortfall of 3,042 primary care facilities across the country. So you can expect that a lot of the resources from the central government as available will be poured in to really strengthen primary care facilities. And of course, these facilities will not work or will not be able to cater to families and households without primary care workers. And this was strongly emphasized by Dr. Domingo, and I agree with it very much. The heart of it really are our healthcare professionals, our primary care workers. So right now, the direction in response also to the UHC Act is to increase primary care worker capacity and competency in providing both individual-based health services and population-based health services. So this is to make sure that your clinic doctor, your public health nurse, your medical technologists at the clinic are able to provide first contact care, comprehensive, continuing, and coordinating care as needed. So right now, the Health Human Resource Development Bureau has already devised a certification process to kind of assess also whether our current healthcare workers have the clinical and managerial capacity for effective primary care service delivery. And this will eventually be expanded to updates and changes in the curriculum such that our newly minted doctors and nurses in the future will be ready to be primary care providers. Standards of care also is a key component to making sure that services are equitable and adequate. So right now, what we have at the DOH is a set process and methodology to determining national practice guidelines and standards of care, which will become the basis for national policies on, for example, quality of service delivery, on benefit packages of PhilHealth, and continuing training and capacity building for our healthcare workers. So this is really not so much to regulate individual practice, but just really to set a benchmark and basis for all succeeding policies in an evidence-based manner. Incentives, of course, and financing is very, very important. And the law is very, very clear also on its two tracks on benefit development. So, and both of these actually capture comprehensiveness as its mantra. So comprehensive outpatient service coverage through a comprehensive outpatient benefit, and comprehensive inpatient service coverage through DRG global-based budget mechanism for our hospitals. The priority right now of both the DOH and PhilHealth is ensuring that we get to this comprehensive outpatient benefit for all Filipinos, again, as part of the championing of primary care as the cornerstone of universal health coverage. So what you can expect in the future or in the coming years is a continuing expansion of the consulta benefit, adding more services, more diagnostics, more medicines, and eventually transitioning to covering the universe of primary care services for all Filipinos. And lastly, which was highlighted by Dr. Domingo as the second most important tenet, system intelligence or health information. So the buzzword has always been about interoperability, making sure that records are connected to each other. But now it has become clearer. We want interoperability, for example, within networks and within integrated local health systems, such that mobility of individuals within their geographic jurisdiction can actually be followed through by information pathways, right? So for example, you get your CBC at your primary care facility and you need higher level care in the hospital. Once you get to the hospital, your records are there already. No need to repeat tests, and networks that are built together recognize the integrity of the results provided by one other facility. So it really is about integrating information and making sure that they are shared within networks. And actually, even within the central office at the Disease Prevention and Control Bureau, what we're moving towards is integrating our individual disease-based registries. So right now, we have information systems for TB, for HIV, for animal bite, for malaria, for etc. So all of those follow through with the vertical programs. But we're trying to break away from that towards an integrated disease prevention and control information system and breaking away from vertical programs towards life stage approaches. So in the coming years, you can expect some information system platforms, apps, and online trackers that will display these changes in our paradigm also in disease prevention. So all in all, those are just some of the key activities, key reforms that the central office in partnership with LGUs are currently pursuing. And I guess just to close it off, I just really want to emphasize the opportunity and the importance of doing all this with the private sector. So as we know, around 60% of our service delivery capacity in the Philippines is brought by the private sector. And a huge, huge part of the response to the COVID-19 pandemic was really brought in also by the private sector. So that partnership between the public and the private system is a non-negotiable. And we just really hope that these continuing conversations like this can continuously happen in the future as we continue to build our reforms towards universal health coverage. So thank you again very much to Liveable Cities Challenge PH for this opportunity, and I hope that that was productive for us all. Thank you and magandang hapon po.
Thank you, Christian. Extremely productive, and we don't envy you. You have a lot of work ahead of you as you begin to roll this out. And I guess we're going to count 2022 as the first year of the rollout. Is that a fair enough statement to say? Okay, so we've heard a detailed discussion from Christian. We've heard the big picture, moral, philosophical, rights view from Dr. Domingo, and we've listened to the detailed city operations of Mayor Benji, and just try to imagine 1,634 cities and municipalities and 80 plus provinces now have to get their arms around this universal healthcare program and implement it. And it's a large, complex system with many moving parts. So before we get to our next question, our next speaker, let me just ask a question from the audience, and I'll ask our team to flash it on. Having listened to all of this, how confident are you in our readiness to implement universal healthcare starting this year, mind you, starting 2022? How confident are you in our readiness to implement universal healthcare? Just one choice: not confident, confident, or very confident. Please be honest with your answers, folks. So let me repeat. How confident are you in our readiness to implement universal healthcare? Not confident, confident, or very confident? Okay. Well, let's start with the very confident. Just 2%. So it's quite low, I would say. And then we have a confident number, 60%. It's a pretty sizable majority, actually. And then 37% not confident. So there's I would say, a very high vote of confidence at the moment in universal healthcare and the ability of the government to implement it, and of course the healthcare system to implement it. So keep that in mind, and let's move on to our next speaker, who will be our last speaker for this afternoon before we go to the open forum. Our speaker is Kashmira Prabhu. So Kashmira is currently the general manager of Sanofi Pasteur. She's the new general manager, actually, incoming. She's still outside in India, but will be making her way to Manila soon, we hope, Kashmira. Prior to this, she was business unit head for renal and transplant section of Sanofi from 2018 to December 2018 to December 2021, and served as deputy director for strategic projects in Sanofi, India. Let's please welcome all the way from Mumbai, India, the new GM for Sanofi Pasteur here in the Philippines, Kashmira Prabhu. Kashmira, the floor is yours.
Thank you, Bill. Thank you. First of all, a very good afternoon to everyone. I'd like to actually thank, at the outset, Liveable Cities for having invited Sanofi to share our point of view. And this being the first lab of 2022 for Liveable Cities makes it that much more special. And thank you. It's an honor and privilege to be joining almost 3,000 miles away from India and being a part of this discussion today. So I'll just share my slides. Here they are. So livable cities, healthier cities. When we say livable cities, what comes to our mind when we hear this term? I would say convenience, infrastructure, better access to public utilities, better public transport, entertainment, leisure, better work-life balance, existence of good establishments, green spaces, of course, better environment, low pollution, and this list can go on. However, 2020 added a new dominant feature to this list, and that happens to be freedom to go about doing our daily chores and activities without the fear of infection, illness, with the basic inherent hope that we are always safe. I cannot stress enough on the fact that COVID-19 and the resultant lockdowns and mitigation efforts brought our cities to a almost a halt, and rather converted them to ghost towns. The pandemic brought with it not just a huge crisis of the disease that we didn't know how to manage, but also brought its own share of very severe economic hardships. We know of the suspension, in some cases closure of business activities, a long period of unpredictability, and eventually it almost appeared as if there was no solution in sight. However, the pandemic also cemented a very concrete fact, the fact that we all are in this together. And if we have to emerge out of this, that also has to be together. I'd like to borrow from Mayor Benji's presentation where, of course, I noticed he said, we work as one and we heal as one. Obviously, no one is protected till all are protected. No one is healthy till all are healthy. And no one is safe till all of us are safe. While grappling with the pandemic, our healthcare workers, who are our frontline heroes, had to face unimaginable strain to not only manage the disease, but importantly save lives and prevent an imminent collapse of the healthcare system. At the same time, the pharmaceutical industry, while trying to provide medicines, unimpeded supplies, also was trying to develop, test, and quickly bring to the consumers across the world vaccines that again could prevent severity of disease and hence save lives. Now, mass vaccinations are underway. Almost booster schedules are up and running. The economy seems to be slowly recovering. And we can safely say that we might be emerging out of the worst of the pandemic, to say the least. And this path to recovery inadvertently puts public health at the forefront like never before. We must not lose sight of the learnings that we have got from the entire pandemic phase, from the crisis. These learnings are not just about managing a future pandemic or a future epidemic or a future health crisis. These learnings are also to look at public health in a new light, not just in managing disease and illness, but rather in an ideal world, preventing what is preventable and promoting health and well-being of the larger population. The other learning from the pandemic, of course, is that diseases don't discriminate, not on basis of income, not on basis of any parameters. When we say this, it means that a concept like universal healthcare precisely is an answer to address this challenge, because universal healthcare at the core believes in providing healthcare access to all those who need it. When the law was enacted in 2019, obviously, at the heart, it believes that it's not just financial access or financial assistance, but rather it believes in providing promotive, preventative, curative, we can call rehabilitative, palliative care as and when to whoever requires it, whoever needs it. The COVID crisis, of course, has put this on hold for some time, but now as we emerge from a crisis mode to a more manage the future mode, it might be just time to look at how this can be implemented at the ground level to ensure that healthcare is accessible to all the citizens fairly and equitably. This is good in spirit. In action, it means healthcare has to be within reach. Accessibility, whether it is doctors, medicines, follow-ups, diagnostics, all of it has to be available, not in a selective way, but in an inclusive way. And that is where public funding would play a strong role, because only public funding and adequate public funding can ensure that every citizen has access to healthcare intervention that they need, where they need, how they need, when they need, irrespective of their ability to pay and irrespective of where the citizen comes from. While we have seen that the mass illness has had an impact on economy and on the society at large, we now cannot afford not to invest in health systems. Healthcare no longer can be seen just as an expense. It cannot be seen as a burden. Rather, healthcare would need to be seen as an investment in human capital, as an investment for our future and for healthier Philippines. And this is where our role is also beyond just the building of the public health system, because we will have a larger role to play as individuals and as a community at large. Vaccines work, and we have seen that vaccines can be simple, powerful tools of healthcare intervention to prevent what is preventable. At this stage, as we are emerging from the pandemic, we also have the responsibility to ensure that our children, our future, complete their vaccinations. They pick up the catch-up vaccinations that were missed during the lockdowns and complete those routine immunizations. At the same time, as responsible adults, we are proud of our COVID vaccination, but we also need to add all the rest of the vaccines that we missed, those shots of vaccine preventable diseases for which we are eligible. So livable cities, of course, will have to be well-immunized cities, because unfortunately, the viruses are everywhere and they look specifically for densely populated urban environments to actually spread their misery. And while we say livable cities have to be well-immunized cities, this will take care of vaccine preventable diseases. But we also have chronic illnesses to be taken care of, and they would need specific therapies to be available so that we can manage the chronic pandemics as well, which exist in our society due to lifestyle disorders. In fact, if a healthier society had to be more resilient, I would rather urge our local governments to also look at how we could bring in healthy habits early on through education and communication of better lifestyles, better healthy lifestyles, balanced diets, exercise, all of which will go in a long way, not just in managing an illness, but rather delaying or completely preventing that illness. Having said this, as I close and I say healthier cities are more livable cities, I would just like to recapitulate on a few points all through, which we'll discuss today. One, I think personal and community health is going to be a permanent feature to decide how livable a city is. Second, healthcare is no longer to be thought of as an expense, but rather as an investment for our future and an investment in our human capital. Third, universal healthcare provides the framework, it provides the vision, it provides the tools which can make all this possible. The fourth would obviously be that vaccinations, of course, work, and we can prevent what is preventable through a better coverage of vaccine preventable diseases. Fifth, of course, lastly, but not, I would of course leave the floor to Bill as I close. Our individual action and our collective resolve to implement all of this as a whole of society will go a long way in determining the success of our plans. The time to act is now. We can build healthier cities, and these will definitely be more livable cities. So thank you on that note, and over to you, Bill.
Thank you, Cash. You know, you're completely correct. When we first conceptualized livable cities several years ago, to be quite honest, and embarrassed about it, we did not think of healthcare. We did not think of healthy living. We thought of the things you thought about: open spaces, great places to work, great places to live, amenities, facilities, transportation, education, lifestyle, things like this, infrastructure. But I think what happened with COVID is that we began to realize how much we've taken health for granted, and how we need to begin to make sure that livable cities are healthy cities. And as you said, I think part of that is how to be immunized, well-immunized cities, because it's in cities, especially in high-density cities, where disease can spread so fast. Not just a pandemic, actually, but any disease for that matter. So it is so important, really, to manage the health of people and the health of a city, of a place, of a region. So thank you for that. At this stage, let me re-invite all our panelists back on screen, back on the virtual stage for our panel discussion and question and answer. And I know there's a lot of questions out there in the Q&A box I'd like to go to. But first, let me invite back on board Dr. Domingo, the national scientist and Ramon Magsaysay awardee, UP Professor Emeritus, and really the one of the godfathers of universal healthcare, having spearheaded all the early studies. So Dr. Domingo, please join us again.
Yes.
Christian Nuevo from Department of Health, if you could kindly join us. Cash, you're already on board. And I know that Mayor Benji unfortunately had to run along, ironically, to also launch a universal healthcare program in Baguio. So he had to leave to another event, but he will be represented by Ms. Antoinette Anaban, the Disaster Risk Management Officer for Baguio City, to join us and answer questions about Baguio City. So let's get everybody on board. And I would like to invite also to the panel Mayor Lani Revilla of Bacoor. I saw Mayor Lani in the audience, and Mayor Lani had a question. Have we added Mayor Lani? Hi, Mayor Lani. Good to see you, and I hope I hope you're handling your isolation well.
Yes, I am.
Good.
We've been exposed several times, so more or less we know how to handle it.
Okay, you had me worried when you told me you're in isolation. I thought you were COVID positive, but you just had a close contact. So thank you, and thank you for joining us. You've been such a regular on Livable Cities for the last 2 years. I want to give you the first question, because I think it's a question on all our minds. that you have. So please go ahead.
Yes, actually, what I wrote in the Q&A box was we understand that PhilHealth has been our regular health provider providing universal health care in the Philippines. And so far, PhilHealth has had the problem of paying hospitals and other healthcare providers in the Philippines. So I would like to bring my question probably to DOH and to other speakers. Do you agree that government should, or the next administration for that matter, would be revamping the management of PhilHealth, but PhilHealth will still stay? It's just a reorganization thing, and probably improve on providing universal health care for more Filipinos. And what do you see? What future do you see when it comes to PhilHealth in the Philippines being our primary health provider in the country?
Thank you, Mayor Lani. Let me pass this on to Dr. Domingo and then to Christian.
Yes.
I had the same question. Should PhilHealth continue to exist or not?
Can I answer now?
Yes, please.
To your last question, can PhilHealth
continue to exist? Yeah,
if it exists, it has to be changed drastically. It has to be changed drastically. But in answer to the mayor, let me say no. You cannot support the financial requirement of UHC as we are doing it now to PhilHealth. The way to do it, and I think Christians will agree, because from the DOH, is that at the provincial level, a budget is submitted to government to cover the expenditure of healthcare. This is a process that has arrived at because there is a council organized for the purpose under the governor. They have a budget, and the expenditure is based on per capita. In other words, you pay per person. For example, you are covering 1,000 person in a community. The budget you will get for primary care will be based on per capita. And how much to spend per person, meron ng marami ng study. The latest one, for example, let me cite this because this is very important, and I will be very specific. The study of Dr. Antonio Dance and company and group done in UP, in which they took care, the responsibility of providing primary care to X number of people. They asked PhilHealth for a per capita expenditure for 1 year, 600 pesos per person. And you know what? After the studies completed, they have a budget of 7 million a year for primary care. At the end of the year, they have only spent 2 million with an excess of 5 million on primary care. So that is the way to go, per capita budget. And that is Christian, that's what the law says, that you give the global budget, various sources, pulled together, given to the provincial government, and said, this is what you are asking for primary care. We give it to you. We audit you at the end of the year to see that you spent it well. So that's
Christian,
my answer to that.
Okay, thank you, Dr. Domingo. Christian, would you like to add to that? Then I have a follow-up question.
Yeah, I think I just want to emphasize what Dr. Domingo said, that it is impossible for just one agency to pay for our healthcare. May that be PhilHealth or even DOH, or maybe even combined. The total health expenditure in the Philippines as reported in 2020, I think is around 700 billion pesos. The budget of DOH is only how much? 100 maximum to 200 billion. And that's the same amount for PhilHealth on a yearly basis for benefit payout. So even if you combine the budgets of the two big agencies for health at the central level, it will not be enough. Of course, we have money at the LGU level. The question really now is to organize our finances such that it will have greater purchasing power. I think we also have to be open to reframing some of our questions. It's not just so much about making sure we have X amount of money to pay for health services, but also making sure how do we make our expenditures more efficient. So right now, for example, when we talk about the very fragmented health system, municipalities have to buy their own medicines at a smaller scale. Imagine if we get to consolidate all the medicine needs of 18 municipalities at the province level. Imagine the economies of scale, how much we can really bring down costs. And if that money, as what Dr. Domingo said, is pooled at the provincial level, you have so much more voice to demand for lower prices or more rational prices for your services. So it really is an approach at both ends. We still need to continuously expand our fiscal space through innovative taxes, through premium increases, but at the same time, be able to channel these resources in the right avenues so that they have strong purchasing power. And in this case, that is seen as a global fund, special health fund at the province level, so that you have that scale to buy for more services at more affordable prices.
Mayor Laddie, would you like to ask a follow-up question?
There's a certain program that government now is implementing, which is the establishment of malasakit centers. It brings government services closer to the people. Would you recommend the Malasakit Center program to be implemented in all government hospitals and be funded by national government in order for people to feel the healthcare programs of government?
Who would like to take that on? Christian?
Okay, I guess. Okay, I guess I do agree that the Malasakit Center really has provided a lot of support, a lot of help to Filipinos, common Filipinos, when they access care in public facilities. But if we follow through with the idea of consolidation, maybe we should also start thinking about what can happen if the budget for Malasakit centers become integrated to budgets of hospital service front. It's paid per patient, right? But if you consolidate that with the budget of the hospital, you actually scale up the fiscal capacity, right? You allow them to buy more services, more equipment that they can equitably provide for all their patients, right? And I think secondly, I also wanted to emphasize it following the question of Mayor Lani earlier, is that PhilHealth is also shifting gears. They're moving towards prospective payment. So hopefully in the coming years, gone are the days where hospitals have to struggle with reimbursements, having to wait for claims. When we say prospective payments, actually money is going to be front-loaded, a lot like a budget, performance-based budget. So imagine a hospital having consolidated resources from PhilHealth, from the DOH or the LGU, and even the Malasakit Center, how much better they can strategize their finances and improve their facilities for better care. So maybe that consolidation is also an opportunity we should pound on in the coming years.
Thanks, Christian. Dr. Domingo, I have a question for you. Again, it goes back to the financing. So you mentioned it's like a global fund. So
yes.
How are the mechanics? Will it be every year coming out of the General Appropriations Act, the national budget, and then that money is then divided per capita, as you said, to the provinces? And then from the provinces, do they then also deploy it to the cities and municipalities on a per capita basis? Are those the mechanics of the way the funds will flow and be used to fund universal health care?
Yes, basically it's something like this. On a yearly basis, the Office of the Governor, in consultation with the Council, determines what health services are to be given this year. So there are recurring services that every year it's there. But supposing you want to add another service, then you cost that, and then you present that as a budget to central government. And central government will give you the money you need. As to sourcing, it's a mixture. They're free to source it from anywhere. Partly PhilHealth, partly PAGCOR, partly whatever syntax, but you are given a budget to work with, to implement. And that is the money given to you is based on your request, and your request that was approved. Something like that.
And doctor, so when a governor gives his request, so there's about 80 plus governors, when they give the request, who are they giving the request to? The Department of Health?
They have to give it to Department of Health.
Department of
Remember
Health.
that in the UHC, the Department of Health is still the major orchestra conductor. No,
right.
They do not do the work themselves, but they have supervisory function.
I see.
So they still have to be performed that job.
Right. So
while I am at it, let me just inject one other thing, because Christian mentioned a very important thing, and that is the role of the private sector. We cannot do UHC without the private sector. Let that be very clear. Forget it if you don't co-opt the private sector. What we have to do is work with the private sector. Give you a good example of how it succeeds. In Germany, it's called the guild system, because the Germans are employed 80% of their workforce, or a high 90% of the workforce are employed. So it is the responsibility of the company to provide healthcare, and they appropriate money. Here is where government comes in. Government says, since you are providing healthcare, you identify who will give the healthcare, and you pay for the money. Why don't you complete the care? Here are additional cares that they need, that you are not covering. We will give you some money to cover for the extra that we are asking. It's working very well. Just like in Ford Motors, Ford appropriates a long time ago $500 per car for the expenses, medical expenses of their workers. And it worked for a long time. They contract private care provider. Imagine the big chunk of employed people already out of your care, because they have a system that is working, which is also universal healthcare. So we have to be imaginative. We will not have one form. We'll have multiples of form. Depending on what is available in a given situation.
Okay. Yeah. Thanks, Dr. Dominguez. No, so it's clear then that all the requests go to the Department of Health. Department of Health puts it in its budget, in its annual budget request, and then they distribute it. That's great. That's very clear. And then, of course, 100% agree with you. To work with the private sector. I assume you're talking about in the delivery mechanism, using the private hospitals to deliver. Okay. Because as you said, this is going to be paid for by taxes, could be sin tax, could be gaming tax, could be sweet drinks tax, as Christian was referring to. Does that mean, as a citizen, I will no longer have to pay into PhilHealth? Because I'm paying all those other taxes to begin with. I mean, well, I don't smoke, so I don't pay a cigarette tax. I drink a little, so I contribute through liquor taxes. So we, in some way, shape, or form, we're all contributing that tax somewhere. What happens then to our PhilHealth premiums? Does it continue? Does it stop? What happens to it, Christian?
So if we look at the provisions of the UHC Act, they actually set a premium schedule until 2025. And then beyond that, of course, premium calibrations will be up for discussion. But I guess looking forward in the future, since we are seeing that PhilHealth will continue to play its role in providing financial support for individual-based health services, premiums will be continuously paid. Now, I know for some, that's kind of a hurtful statement to put forward, because a lot of us have not been enjoying PhilHealth benefits. But I guess what I just want to point out is there are benefits to paying PhilHealth premiums that cannot be afforded by paying innovative taxes. One of which is that PhilHealth premium payments are specifically earmarked for health. It goes to the budget of PhilHealth, which can only be used to pay for health services. When you pay for sin taxes, sugar sweetened beverage, or your general tax, this goes through the national fund and will have to be allocated across different sectors. So in effect, health is actually competing with agriculture, with education, with public works, etc. from that general fund. But PhilHealth Fund is protected. PhilHealth Fund is just health, right? So there is advantage to continuously paying PhilHealth, but I do also strongly emphasize that payment mechanisms will have to change so that that money is properly used, right? So, right, but the health sector historically has been what, third or fourth always in terms of size of budget versus other sectors, right? So do we want to be second or first? Probably yes, right? Since we're all health advocates. But how realistic really is that, right? Because that will, to some extent, siphon out money from other sectors, which are also very important, especially if we're going for social determinants of health. So there is value to putting in money to PhilHealth, if only to earmark it for health services. But the money really has to be facilitated correctly through appropriate payment systems.
Okay, thanks. There's a question here for Dr. Domingo and Mayor Benji. No? So, Antoinette, I don't want to put you on the spot here too much, but the question has to do with, is the Mandanas ruling going to be helpful for the city or not in this particular case? I mean, will it help you cover those universal healthcare costs?
Yes, sir. Actually, the city of Baguio is a pilot area for the UHC implementation. And in the institutionalization of this UHC, we observed that there are a lot of resources that are needed po. Like for instance po, in terms of the number of doctors, because and specialists, because we are following a standard ratio po. Based on the DOH standard, we have to comply with that first, and that it is very expensive, very costly for the city to implement the UHC, but we are looking at the long-term benefit that the city will get from the implementation of this UHC.
Yeah, but the city will get a share of an allocation from the provincial, or are you an independent?
We are a chartered city.
A chartered city. Oh,
yes, sir.
So what happens to chartered cities? Do you get a share of the provincial budget, or you're on your own?
We are on our own po.
So, Dr. Domingo, what happens in the case of a chartered city? They're not jurisdictionally, they're not part of the province.
Yes. The general feeling is that the chartered cities, especially those that are working quite well, maybe Baguio is one, Makati, for example, Manila, is to be let alone to continue what they're doing.
Okay.
Because they are doing it well. They're doing it well.
Okay. And they can file for that budget request through Department of Health as well.
Oh, I think what I articulated is actually, if I'm not dated, is at the position of the DOH, that the cities that are well organized, let alone, but they are open. They are able also to access help from central government or provincial government.
Okay. Thanks, Dr. Domingo. That's clear. Cash, I have a question for you. So let's just do a little comparison. In India, is it a universal healthcare system in India?
In fact, I think Bill, you brought the point right up there. In India, of course, there is a vision for the universal healthcare, but it is still not, we would say, completely as developed as you would see in many of the other parts of the world. Examples that were coming up, and the challenges are similar again. However, in the overall vision, there is a program called Ayushman Bharat, which means Long Live India, and that's clearly talking about not only funding, but also developing a system, a tiered system of healthcare, where people can, it will involve upskilling of healthcare providers, because the numbers will never be enough. We face similar challenges as Philippines. the same challenges as you'd say emerging markets typically, and there's always a challenge of prioritization of the funding. One thing that COVID, I can say, has the pandemic brought to the fore, and which is a learning, is that we have a federal system, and then of course we have our provinces, but empowerment of the provinces has gone a long way in faster, speed of action. So, and that brings in the innovation also up there. So I would say we have still a long way to go. The vision is similar, but today the first piece before COVID that we were able to achieve was providing financial access and financial assistance to almost 50% of the population who are below poverty line. But that, like I said, is not enough, because it's not about funding. It's about actually having a system which runs, in parallel effectively.
Thanks. Dr. Domingo, I have a couple of questions here. One is, the operative word is universal. So does that mean it's like automatic enrollment for a person at birth into the system, so they're covered in the system, or will there be need to obtain an ID for this?
Yes, by virtue of citizenship.
Okay.
As long as you are a citizen, you're covered. That is the essence of universal health care.
Right. So no need to obtain special identification. Nothing.
No.
Okay. Okay. That would be perfect. And from your studies, has there been an estimate of how much it would take to fully implement universal health care?
Well, we have to start with what Christian is saying. What is the annual health expenditure of the country? And Christian, you mentioned about 800 billion.
Around 700 to 800 billion already.
Billion. That is the total money the population spent. Now, if you analyze that further, Christian, correct me. At least half of that is paid for from out of pocket.
I was going to mention that. I mean, it's a big number, yeah, but it's out of pocket. It's personal.
So yeah. So with those two figures, maybe you can figure out, Christian, how much more to add to the 800 billion to do this, no? But you see, we're spending the 800 billion, but if you have a system that is very efficient, you can do a lot of savings. Let me give you, the national health expenditure takes all the money we spend for health, but I will give you very specific example why many of them are wasted. For example, look at the executive checkup. You can have executive checkup in the range of 100,000, but that does not mean it's more effective than an executive checkup that is only about 10,000. It depends on the healthcare provider, because if he's careful, if he knows what he's doing, he does not have to have so many examinations to diagnose a disease. I'll give another example. Why will you mandate somebody to have a stool exam simply because he has diarrhea? To us specialists who are dealing with this, I am a particular example. I have forgotten when was the last time I requested for a stool exam. Totally unnecessary in many cases of healthcare. That is already a savings. No? Somebody who's already only having sniffles, bakit mo ipa-chest x-ray routinely? You see? Yeah, there are so many of that in healthcare. It is only when you tighten the screw and say, oh, you don't have all the luxury of money, you better justify everything that you request. Then you will find out that there is a major shift that will generate a lot of savings. Yes.
No, that's a good point. Christian, in your presentation, you talked about the sort of the fragmentation of the system and then sort of how to get it reintegrated. One of the things we observed in the private sector when we helped the government on this COVID response program is that we learned that, city hospitals are managed by the LGU, but provincial hospitals are managed by the province, and and regional hospitals are managed by Department of Health. And we had thought they were connected, but it turns out not so
They're
connected.
not. Yeah.
They're not so connected. So walk us through again how you see this integration when UHC kicks in and funds go in through the provincial. Does that mean that provincial and city hospitals will now fall under one umbrella, or just dip into the same source of funds so that they can have a little more efficient use of money?
All right. I guess I'd like to respond to that by highlighting two levels of integration: integration at the service level and integration at the governance level. So when we talk about integration at the service level, that's where we connect primary care facilities with inpatient facilities so that there's continuing care from preventive to palliative, for example. So standards, of course, are going to be set in terms of what services should be provided by a network. So networks might have different configurations. Some might have their primary clinics linked to a level 1, a level 2, and a level 3 hospital. Some might only be linked straight to a level 2 and a level 3 hospital. So depending on the standard set, as long as a particular network can fulfill all those service delivery requirements, then they can be considered a network. So if it's a mix of public and private, all public and all private, well and good, as long as standards are met. So networks can be formed like that and integrated like that. The second type of integration is when municipalities actually are brought up to be integrated with the province, right? So currently in the local government code, they are completely autonomous. But what the UHC Act wants to happen is actually for provinces and their component municipalities to work together as one unit, right? So you can't link your rural health unit with a provincial hospital if your municipality and your province are also not connected to each other, right? So the idea is to integrate at the province level such that the leadership is shared by local chief executives at the municipality and provincial level. So think of it like a company where the mayors and the governors are like the stakeholders, and then the individual facilities that are linked together form the arms and feet of the company providing the services, right? So they become like the provincial health board managing the local health system. And the money, PhilHealth, for example, all the payments will come into the special health fund, as what Dr. Domingo mentioned. And then the budget of the municipality and the province can also be pooled at the special health fund to really maximize the space. And then from there, they can reallocate. Maybe, for example, they want to invest more in primary care, pool their money and build primary care infrastructure, hire more primary care doctors and primary care nurses to really beef up that level of service delivered. So integration will have to happen on those both levels, the governance level and the service delivery level. So the Mandanas ruling actually plays a huge role in this one. So the money really is going to pour into local governments. The estimations of the DOF is that 30% expansion in fiscal space of LGUs. And all of this is going to be distributed to cities, highly urbanized cities or component cities and provinces, and all will experience that boost in resources. So all the more we take this opportunity to really consolidate and better use our finances.
Yeah, thanks. Well, the cities are all looking forward to their 30% boost in budget, but they've been warned that they may be getting more responsibilities to spend for, and that it may outrun their 30% increase. Let me shift. But thanks, Christian, for the answer. Let me shift the question back to you, Dr. Domingo. It's about medicines. Okay. There's a couple of questions here regarding the use of universal healthcare for medicines, which are paid for a lot of it out of pocket by people, and also this idea of subsidized medicine costs. What's your take on that, Dr. Domingo?
Universal healthcare is absolutely committed to supporting the expenditure on medicine. It's part of the care. Like, for example, if you are hypertensive and you need hypertensive medicine, you don't have to buy it. It's given to you. And when your supply run out, you can go back to your healthcare provider and they have to give you. So you don't separate expenditure from medicine from expenditure from a laboratory. It's a universal coverage. It's a universal coverage. So
okay, and
even preventive procedure.
So the mechanics will be generally that so long as you receive some sort of a prescription or doctor's orders, you can obtain the service or the medicine for free.
Well, if the medicine is supplied by pharmacists, like our Mercury, in some universal healthcare system, for example, in Taiwan, when you are given a prescription, you can get your medicine in any pharmacy.
In any pharmacy.
It. Yes.
Yeah. And then the pharmacy collects from the government, I suppose.
Yes, absolutely. They carry a card that credits what was given to you. But in another situation, when you don't have a pharmacy, the healthcare provider themselves should give it. So you go to your doctor at the end of the month, my medicine for last month is already exhausted. They have to give you.
Yes. Okay, no, I get that.
That's being done in some areas of our country, so-called GIDA, geographically isolated.
area.
Ginagawa yun ng DOH. Hindi ba, Christian? Ginagawa yun ng DOH. Yeah.
You should communicate that more, Christian. I think people are not aware that that's happening, no? Okay, we have so many questions, but I'll ask just one last question. You mentioned it briefly, Christian, about health information. So in this case, what will happen? Will the information be stored in a way, as you said, accessible wherever we go? So it's got a bit of portability to it, and presumably you'll have enough security measures in the system. Is that the direction it's going to be going in?
Yes, definitely. But right now, what's at the forefront of the discussion is that the portability of your information is within your network, because the assumption there is that the team of doctors in health facilities and other health workers within the network are the ones taking care of your health, right? So the portability of that information is within your network. But at the central level, of course, we have a national repository, mostly for surveillance and policy decision-making purposes. But at the service delivery front, the portability is within the network you are part of.
Okay, and will Department of Health build up that particular competence for health information, or will it go out to DICT or contract it out? The reason I'm asking is I take a look at the vaccine program now, no, where they're trying to get the VaxCert PH going, and we can see there's a real struggle in getting the information in, because it's got to be encoded by the different LGUs, and there's a massive backlog in the VaxCert PH program. So how will you address that? You're going to have to equip a lot of people with the right skills and of course enough IT infrastructure to get it done. Will DOH manage all that, or are you going to get another agency like a DICT to help you?
So definitely partnerships will have to happen, for example, with DICT, because in the future, the vision of DOH really is to pivot more towards standard setting and facilitating mechanisms for interoperability, but not so much anymore about paying for hardware or equipment. That's actually really beyond the scope of what DOH should be funding. So we look into partnerships with the DICT, for example, and actually even LGUs will hopefully get the opportunity to invest more in their hardware so that they also have strong information systems. But the DOH really will focus mostly on standard setting. And it is going to be a process of transition, definitely, but that's the vision in the future.
Okay, thank you. Yeah, thank you. There's so many good questions today, and we learned a lot. But as usual, we always run out of time, and these things and these sessions have to come to an end. So I want to thank, first of all, I want to thank our speakers today, Mayor Benji and Antoinette, of course, representing him on the panel. Dr. Domingo, thank you for the, what was, I think, one of the clearest explanations of universal healthcare that laymen like us get to hear and listen to. Christian, thanks so much also for walking us through the details of what lies ahead for you at DOH. You've got a tough job ahead of you. And Cash, thanks for giving us your perspective from the private sector of what universal healthcare is going to be like, with good, strong private sector participation in the execution. And Mayor Lanny, of course, thank you for joining us again and for giving us your perspectives, from the local government side. And really, everyone, all the mayors and all the private hospitals, they recognize your pain. When you talk about PhilHealth not reimbursing the hospitals, it's been a constant battle with us at Task Force T3 throughout the COVID response, trying to get PhilHealth to address the hospital requirements. But thank you for raising that. It's been a great session. And before we close, I just want to remind the audience that there is an event evaluation form. So as you hit the exit button, that automatically appears, and we hope you take a few minutes of your time to answer those questions. If you're on Facebook, there's a QR code that'll appear on the screen. Take a picture of the QR code, and that'll lead you to the evaluation form. So the feedback's always useful for us, and for those of you who need the certificate of participation, you get it when you fill in the survey and return it to us. So thanks very much. But again, my thanks to the speakers, Dr. Domingo, Mayor Benji, Christian, and Cash, and to all the audience. Great questions. And I'd like to thank, of course, our partners at Liveable Cities Challenge. Today, for the first time, we have Sanofi Pasteur, and we look forward to a long-term relationship with them. We're working on the health dashboard with Sanofi as well. And of course, the League of Cities of the Philippines and Globe Telecom as our regular partners. So thank you very much for joining us for this first Liveable Cities Lab of 2022. We have a very active program for the rest of the year, touching on subjects like health, like resilience from natural disaster, intelligent cities, many other topics, sustainable futures and smart buildings and better homes and things like this, that all make part of a livable city. So thanks for joining us, and we look forward to seeing you in our next Liveable Cities Lab. Thank you and good afternoon.
Thank you.
Thank you. Thank you.
Thank you. Dr. Domingo, thanks so much. Such a pleasure to listen to your explanations. Christian, you as well.
Thank you. Thank you. Thank you.
Thanks, Doc.
Yeah.
Thank you very much.
Thank you. Thank you.
After that, please thank Mayor Benji for us.
Thank you.
Thanks. Cash, thank you. Look forward to meeting you face to face when you get here. And
yes, of course.
and of course, we welcome you on board as a partner of Liveable Cities Challenge.
Thank you. My pleasure.
Yanni, thanks.
Sure.
Ivana, thank you.
Thanks a lot, Bill, Yanni, and team. Thank you.
Yep, thanks everybody. Erin, Patrick, Mao, Mick-chan, Maricel, thanks everybody.
Thanks.
That was
A
really
very good discussion.
No, very good, very educational. I mean, I learned a lot. I didn't know the money runs through the provinces.
Yes. I learned that from Dr. Domingo. When I interviewed him.
Yeah. It's gonna be interesting how this thing is gonna be all roll out and get implemented.
Yeah.
Okay. Thanks everybody. Yep. Take care, guys.
Thank you.
Bye. Thank you.